I'm here at Greater New York Dental Meeting, and I'm here with my buddy Doug Schulz, who is one of the first guys to ever use CAD-CAM.
Well, I'm an early adopter, so I won't say...
Very early adopter.
Yeah, 1997, 1998 was the first voyage into Cerec communities.
Is that my copy? So it was, what year, 98?
98.
And that was Cerec 2.
That was Cerec 2. It was not Windows, it was DOS. If you remember DOS, you had a screen with 3 different windows that opened up, and they weren't even windows. There was a projection screen, there was a cut screen, and there was a something else on there, if I remember right.
And talking to the Cerec people, because I got Cerec 1. I think I got Cerec 1 in 89.
Probably.
And then 2 was, you said, 97?
97, 98.
But when you look back at the journey of Cerec between Cerec 1, Cerec 2, Cerec 3, and it really wasn't a must-buy till probably Cerec 3.
3 and 3D came out, and then 3D. It became really, really motivational for docs to buy it because they understood Windows.
But when you talk to the Cerec scientists going all the way back to Germany, it was the problem with Cerec 1 and Cerec 2 was the computers weren't fast enough.
The computers weren't fast enough, but also we didn't have the ability to do crowns. So when crown software became available in, I'm going to say, 97, 98, Cerec 2 then became viable because a lot of docs wanted to do crowns. They didn't want to do inlays and onlays because when you got Cerec 1, you could just do inlays. So you could make a piece of porcelain that went into the tooth that reinforced the tooth, and then you equilibrated it in and ground it in like crazy and had a great restoration. And I still taught a doc back in 2004 that was still using a Cerec 1. And until he saw Cerec 3D come into play, he said, I'm still going to keep using my Cerec 1. And then 3D came out, which really changed.
What year was that?
I think 2003, 2004.
Okay.
And that changed the whole environment. And it really put it out there. It was a lot easier. And now with the Omnicam, it's really simple.
And explain what that means, that the Omnicam versus the 3D.
Okay,
the
so in the early stages, we always had powder to deal with. So with the red cam, the blue cam, we still had powder. First, we had titanium dioxide, and we had all sorts of different devices. Do you remember ever a powder meister that somebody came out with?
Yeah.
Spraying this, and it was clumpy. You had to filter this powder. You had to shift it. You took a Coleman fuel filter to filter your powder, and then you filled up your powdering machine and you powdered the tooth, and we had this white coating, and so you had to take compensation for that in your cement thickness and how you design your restoration. Well, then along came the blue cam, and the blue cam still required powder.
What year was the blue cam?
2008.
Okay.
15. Omnicam's been out 3 years. 2008, somewhere in there. The blue cam came out from the red cam, and then we got into OptiSpray. And OptiSpray was a spray that was a much finer, it's like misting the tooth. And we never really said powder was an issue because it wasn't, because that's what we had to use. But now that we don't have to have powder, that's where the Omnicam comes in. So we now are into streaming color video and converting that into 3D models instead of taking images. So stitching images around an arch is different than streaming video of an arch. So the accuracy of Omnicam versus blue cam for full arch restorations improves greatly.
So what would you tell a young kid now who doesn't have CAD-CAM? And I'm just going to play devil's advocate with you. They're saying, I just got out of school. I got $350,000 student loans. I just bought old man Charlie Schulz, his dad.
Exactly.
His dad has the drawer of peanuts and Lucy. I just bought old man Charlie Schulz practice for $600,000. So I'm almost $1 million in debt, and now Doug's coming along saying I should buy a $150,000 CAD-CAM. What would you say to her? She's scared.
I know.
That's a lot of debt.
I'd be scared too. I was scared. And the thing is, if your practice is doing a certain number of restorations, I don't care what it is, all you have to do is look at the number of restorations you're doing on a lab bill. Because really, when you buy a digital imaging system, you're just trading lab dollars. You're going to either pay a lab guy X thousands of dollars a month, or you can keep that in-house and then, control the quality of your restorations.
Okay, but talk specifically, what, how many restorations, what is that payment?
Well, you have to look at it. You can look at it two different ways. You can look at it as far as what your lab cost per restoration is. So if I'm paying $100 to $150 a restoration with my local lab.
Is that about the average, 100
yeah,
150?
Yeah, and you can go to a middle lab where you can go I'm going to say Glidewell. He's the Walmart of dental labs in the U.S. You can get an EMAX restoration for $99. So the difference is going to be, I get a Miller block that's $26 versus $100. So every restoration I'm going to make, I'm going to save $75, but really I'm going to save a lot more because you have no temporaries, you have no impression materials, you have no second visits to do because single visit dentistry is really the savings. So whatever it costs you to turn a room over.
And explain that again. That might have gone over.
Okay.
Everyone's head.
So if you do 2-visit dentistry, where you take and prepare a tooth, put a temporary on, you've got the cost of making that temporary, which has a fee. I don't know if it's $10, $20. You've got the cost of an impression. And if you have to retake the impression, you've got double that cost. So let's say it's $25 every time you take an impression. So now you've got the cost of the temporary, the cost of the impression material, and then you have to change the room over. So if you look at Gordon Christensen's, every time you have to wipe down a room, the downtime of that room, you've got a cost associated with that. I don't know, $45, $50. So now you're saving that time because you only have to see that patient one visit.
It reminds me of when you and I were little. You're from Iowa, I'm from Kansas.
Right.
And I went to UMKC Dental School in Kansas City. You practice in Kansas City now,
I do
right?
practice in
But
Kansas
you didn't
City.
go to Kansas City.
No.
You went to University of Iowa?
Correct.
And but when we were little, so many farmers had a semi-truck, and a lot of times they would do long hauling as a side job. And they all went bankrupt to big firms that got rid of deadheading, which means the small town farmer guy in Kansas would take a load from, say, Wichita to Omaha, make money, but then drive back empty. But it was the national chains who could coordinate that. Well, if you drop off something in Omaha, we'll schedule you something to pick up in Omaha and bring it back to Wichita. And it was the efficiency of not having a deadhead, or what you call a second appointment, coming in when nothing's going to be billed out.
Exactly.
And when I go into dental offices and I'm looking at efficiencies, it is crazy how some of these dentists, they're only billing out revenue maybe 20% of all the patients in that week because he had this guy come back just to check the bite. He had this guy come back just to check this. This one was just an ortho adjustment. And you're looking at the schedule and say, how do you have 100 people Monday through Friday and you're only billing something out on 20 of them?
Oh, that's crazy.
And then you want to know why your overhead is 74%. And so what you like is the second point. So I'm going to keep playing devil's advocate. So what would you say? Because I understand what you're saying is if you're going to pay $100 a unit to the lab, why don't you pay buy the block for $25 and pay $75 to yourself?
So if you've got a $2,500 a month payment for your equipment, you've got to make enough on top of what your costs are to mill those blocks or to mill those restorations to pay for that payment. And everything above that goes to the bottom line. So
now, is that about the monthly payment going to be about $2,500?
It is. If you finance
for an
for an Omnicam, the milling unit, a porcelain oven, you're going to be $130,000, $135,000 plus tax.
And that payment over, what are you talking about?
5 year, let's say a 5 year.
5 year lease to own is going to be $2,500?
About $2,300 to $2,500.
Okay.
And it's the doctors that do a ton of restorations, that do 30, 40, 50 restorations. But really, the savings point is you convert a lot of big composites to ceramic restorations. And then we can talk about the benefits of doing ceramic restorations versus big composites, because you and I both know big composites just don't last.
Right.
And they don't strengthen a tooth.
I want to talk about something else with the Omnicam that I see that I'm doing a lot in my practice.
Okay.
A lot of times in my practice, You're pulling in emergency, you got a broken tooth, things like that. And I don't have time to do the whole Cerec thing. But I'm using the scanner and taking a digital impression, sending it to a lab. What are your thoughts on that?
I do about 99% of my stuff in-house, but the beauty of where the technology is going is that you can delegate a lot of it now. So before, when you had to powder, you really needed two people to keep the tongue and the cheek out of the way. You could use an isolite and everything like that, but you still needed, it really was a technique-sensitive type procedure. Today with the Omnicam, I could hand it to your son, and he can take that Omnicam and take a scan of an arch. And all you have to do is say, fill in all the voids, make it look just like you see it in the mouth. So teaching auxiliaries, assistants, hygienists to scan is a real easy process today compared to where it was 5 years ago. So now, you break a tooth, you come in. It's a real easy procedure. You talk about those offices that don't bill out procedures. You got to be able to do same-day dentistry. And that's the beauty of Cerec technology is put them in another operatory, take a scan, get them numb, get a hygienist to get them numb. Your time chairside is going to be minimum because I can just go over and prep a tooth. I can do an onlay, an inlay, a full coverage crown, whatever it is. They can scan the opposing, the buccal bite. I can finish the scan of the prep, and they can design it, mill it, try it in, stain and glaze it, and I can be there and submit the final restoration.
And how much time are you talking about between when you first numb up the patient to when you cement?
Hour and a half or less.
Hour and a half or less.
Yep. When you get your systems down, but let's say it's 2 hours.
But are you saying that you never in your real world never get to a point where I don't have time for this? I'm just gonna send the impression, digitally scan the impression, send it to a lab, because I seem like I'm doing that more and more. From just an operations and logistics point of view.
No, I really don't, Howard.
Huh.
Yeah. We always find a way to work it into the schedule. Or, if somebody breaks a cusp off a tooth and it's not sensitive, you can put some temporary material in there. You can leave it. You can take a sharp edge off and say, okay, tomorrow I've got an opening here, or next Tuesday, what's good for you? You always want to take somebody out of pain.
I want to ask you another thing that's huge in our industry. So what percent of the Cerec posterior crowns milled out in a dental office would you say are EMAX?
Probably 95% of them today.
Yeah. So what do you say to some guys who say, well, is Bruxer stronger? Maybe I should be taking the Cerec and scanning it and sending it to Glidewell to make a Bruxer.
Why?
Because some people believe that the Bruxer is stronger, so they don't break the crown.
Why? Because EMAX doesn't break either.
Do you feel that way?
Oh, totally. In probably the last 5 years, I may have had 5 or 6 posterior restorations break.
And how many years?
5 years.
So you're having one a year?
Yeah.
Well, I think some people think that, some people call it the aesthetic health compromise, where EMAX is for beauty and Bruxer is for strength. But you don't really see it that way?
Talk to Rella Christensen. I've been doing the 5-year study with monolithic ceramics. So we've tested Bruxer. We've tested layered Bruxer. We've tested EMAX. We've tested lava, enamic. They don't break. So the question in dentistry today, how strong do you need? I think people go to Bruxer because it's an easy one to cement.
Right.
So you can get a crown, squeeze some cement in, dry the tooth off, and shove it home, clean it up, and you don't have to bond. But if you're doing same-day dentistry, where you're doing EMAX, you really want to bond them on because you get the strength from the bonding.
Okay, will you go through your bonding, how you bond an EMAX on, step by step?
Protocol is really got to be there because bonding is all technique. So you got to have the isolation. You can't have saliva. You got putting a cotton roll in. So an isolite or some isolation device is really critical.
And what are you using?
I'm using isolite.
Yeah. Well, will you talk about that? I think
an
isolite
is a great device. Tom and his group over there have all sorts, from an isolite to an isovac. It has light, it has suction, it has a bite block on the other side of the mouth. It keeps the tongue out of the way. It wraps around the distal of the second molar and keeps the cheek out of the way.
That would be. I'd love to do a podcast with Tom. He's a dentist.
Yeah.
The founder of
Tom
Isolite.
Hirsch, yeah.
Tom Hirsch. Yeah, Tom Hirsch. He's the founder. Because what I like about Isolite is I'm 53. How old are you?
Okay, 62.
Oh man, you look good.
Hey, thanks.
I had no idea you were older than me. Well, when you're 53, magnification's important, but so is light.
Light's incredible.
And the Isolite, it retracts. It keeps trying. But there's so much damn light in there that with my 3.8 magnifications, I really feel like I see what I'm doing.
Well, if you have a headlight, and I switch from one headlight to another, so you really need to talk to somebody from ProLight. ProLight's a really neat new light. I mean, most of them are LED today, but instead of having a switch, and a lot of times you got a little switch on your battery, the ProLight has a button about this big, and you hit it with your elbow, and it turns it on and off, and so you don't have to.
Oh my God, I want to see that, Ryan.
So
I want to see.
Find that.
Can you send that guy over, or just tell me the booth?
I'll try to find.
Because you know what I hate the most about my headlamp?
Yeah.
What I hate about the headlamp is, people say, oh, well, you don't have to adjust the headlamp. Yeah, I don't have to reach up and adjust the headlamp, but I have to reach back and adjust this stupid, silly thing. And you move wrong, and the dial turns. And then the other thing that's hard about it is in between patients, how you hang it up moves the lens, moves the light, moves.
You'll love this one because
okay. And what's it called?
ProLight. ProLight. PROLITE.
And what is it? www.
ProLight.com, I think.
PROLITE.com?
Right.
Huh. Okay, well, I'll look for that.
And I'll see if he's got a booth here, and if not, I'll send him over.
So go back to what cement how do you bond on an Emax?
Okay, bonding, and there's multiple bonding systems, and all of them are good. So, but I etch enamel. I don't use self-etching cements. So if I have a ring of enamel around a preparation, I etch that with phosphoric acid for 15 to 20 seconds. I try not to get etch on the dentin as much as possible because now the bonding agents, whether we use Ivoclar's adhesive or whether we use 3M's, Scotch Bond, whatever, a lot of the bonding systems are self-etching, self-bonding, but I don't believe that they really bond enamel properly. You don't get the optimum bond strength. And when we're bonding to structure, we're really looking at, I don't care if it's a little ring of enamel that's left or not, that's our key. We need to really get that bond complete. So then you follow a manufacturer's directions, and most of us don't read manufacturer's directions. So a lot of times you'll get an agent, you dip your assistant gives you your little brush, and you put it on the tooth and you blow it dry, and you forgot to read that it said scrub it for 20 seconds. And you really need to scrub it for 20 seconds if it says that, because you need to get the hema down into the tubules in the dentin so that the bond into the dentin is as complete as it can be, plus your sensitivity goes away. So now, once you've done that, then you got to follow the directions. Does it say to air dry it for 5 seconds or just blow it dry? Whatever it says for that manufacturer, follow those directions. Because each system is different, and you're going to use multiple systems because not one system is right for every restoration. But we've got a lot of good manufacturers to choose from.
So a lot of scientists in dentistry are saying that one of the biggest problems in adhesive dentistry is that oftentimes the dentist light isn't even working, and that some dentists don't know their light's not strong enough to cure for a year.
Yeah.
What would you say about light? What do you think about that comment?
Oh, I totally agree because I've gone through that. So I use plasma arc curing lights, and
who makes plasma arc curing lights? Is that the name of the company?
No, it's a really high intensity light. So we're talking 23 to 2500 lumens of output.
Is that the Denmat Sapphire light?
Denmat makes one. I use one. I don't even know who makes it anymore.
But you like plasma arc lights better than LED?
Not anymore, because LEDs have now become more powerful and more powerful and more powerful. But you need to get one that's 1,000, 1,500 watts or whatever the measurement is, so that you get complete curing. And the other thing you have to check is there are certain bonding agents that bond at a low wavelength, and there are certain ones that bond at a high wavelength. And sometimes with certain plasma arcs, you'll have it only putting out a high wavelength, and then you get into a product like Ivoclar's new Relax, or not Relax, but Ivoclar has the new aesthetic cement, and it cures at a lower wavelength in the curing. So you need to have a light that really has a broad spectrum of output so that it cures all the materials. And there's so many lights out there now. The blue phase from Ivoclar is one of my favorite.
And are you one of the kind that likes to, when you cement your Emax, tack it, then clean off excess cement? Or do you like to clean off all the cement and then cure?
Well, I don't like to clean it all off, because if you do that, you pull the cement out of the margins. So I'm kind of a combination. I like to tack it, peel it away, but I like to have a little extra at the margins, because if you remember that air-inhibited layer, remember your dental school stuff, you still have an air-inhibited layer that doesn't cure at the margin. And then you wonder why you have that little black line that happens at a margin. Well, if you peel that off and the air-inhibited layer then goes away, you've got that little gap at your margin. And then 3 years down the road, you get this little black line. You go, wonder what happened. It's because you pulled the cement out of the margin.
I always think it's funny when ladies come in your office and they're 50 or 60 years old and their tooth just dies, and they're always like shocked, like, well, why would my tooth just die? And I always try to tell them, I say, well, humans are about 50,000 years old, and at 4,000 years ago, the beginning of the Neolithic age, they were living about to 17 years of age. And then at the Copper Age, they made it to 36 years of age. And now they're averaging 74 years of age. So obviously some of these teeth that we crown, whether it be with the Emax, an Emax or whatever, later they're going to die. So someday we're all going to die. Every tooth's going to die. Yeah. But so someone comes into your office with an Emax crown and now it needs a root canal. Are you going to prep an access hole through the Emax, or are you going to just take off the whole thing?
I'm going to take off the whole thing.
Now, I do that too. So I see some of these cases on Dental Town. It's like they're trying to do this root canal through this little BB size hole, and to me, just taking the whole damn crown off.
It makes access so much.
Talk about that.
Well, being a Cerec dentist, it's easy to remake a crown. I hate to see in somebody's mouth an old PFM that's packed with an amalgam or a composite, because like materials just don't bond, and you go, okay, I've had a root canal, but I've got this PFM, and now somebody puts a composite in here, and you see the staining around it, and you go, okay, it's just it's a cesspool for bacteria underneath there. So I guarantee you it's leaking, but it doesn't hurt. So then one day you finally convince the patient to take that crown off, and it's mushed underneath there. So you really don't have a lot to restore. So, you think about the quality of care. We get paid very well for what we do. And so we have to make an access hole in it. It's your choice whether you charge the patient for a new crown or not. But if I just did a crown in the last couple of years and the tooth goes south, we have the ability to do that very economically in a practice and not really do the patient a favor, but it makes me feel good about how we practice, that I stand behind what I do. I can restore that tooth, and now I don't have leakage. And really, leakage is what kills teeth today in the dental world. Leakage around a Class 2 composite, leakage around a crown. The good thing with ceramics, we can see underneath it through an X-ray, so we can tell if we get massive leakage. Failure, They don't debond, but you'll see if you get decay.
So, I agree. I warranty everything I do 5 years. So if I did that crown 4 years, 11 months, and 29 days ago, I'm going to warranty it free. But a lot of that is selfish reasons, because for me, it's so much easier to do a molar root canal with that crown off.
It is.
It's lowered the top 2 millimeters. The prep is flat, so I'm not...
The file length is less.
Yeah.
You can see what's going on. And today with rotary endo, it makes it so much faster.
So I want to ask you, the big, everybody's talking, we're at the Greater New York meeting 2015 in Manhattan. Everybody's talking about the big Dentsply, Sirona merger. I mean, That's two big companies
It's
got
fantastic.
married. What do you think of that merger? Does that affect the little guy dentist like you and me, or not really?
No, it's great for all of us, because you have a company that is totally about products. Dentsply is everything from ankylose and Astra implants to impression material to every supply you can imagine. And Sirona is a technology company. They have treatment centers, Cerec, Galileos, Schick imaging, but they don't have the consumables. So you're looking at a company that now becomes a mega company, a company that's going to have great power within the field to do a lot more. Deeper pockets.
So I want to ask you, one of the errors of thinking is linear thinking. When you and I got out of dental school in the 80s, there were 15,000 crown and bridge labs in America. Now there's 7,500.
Yep.
Are you a linear thinker where you think it's gone 15,000, 7,500, and it's headed in 25 more years down to 2,500? Or do you think this is more of a pendulum swinging type of deal? And do you think labs are going to make a comeback?
I don't think labs will make a comeback, but labs will put their emphasis in different areas. So as we do more implants, you will see more bar-retained overdentures. You will see more screw-retained dentures. You will see more all-on-4 type procedures because the baby boomers have more money. You will also see dentists doing more and more in-office posterior single units. But when you get into larger cases, the average dentist doesn't want to do that. You get into veneers, cosmetic things. They're going to send that to the lab no matter what. So the labs have to position themselves as aesthetic masters, not just, I can wax up or now it'll be, I can mill out 50 units out of a puck. Those will still be there. But you're going to have to segment yourself and position yourself in the aesthetic world, because we just keep wanting more and more and more as far as how we look.
So, are you also placing implants yourself?
I am.
And so tell us about that.
So,
how long you been doing that, and what are you doing?
Oh my gosh, my implant journey started in '82. Got out of dental school in '80.
You got out in 80?
Yep. Practiced at Iowa in Cedar Rapids for 2 years and taught at the dental school in the process department for 2 years at Iowa, and then got married, and my wife was a dentist, and we decided to locate and finally finished up in Kansas City. So bought a practice and had the pleasure of practicing with a doc who was placing blades and subperiosteal implants. So my first venture into implants was blades and subs. What a change. Flapping a whole lower arch, taking rubber base impressions, having Dan Root fabricate a titanium framework overnight and sedate the patient again the next morning, screw it on, have 4 posts, put a denture on it, and do. But it was a great service. But then along came root form implants. And at that point, root form implant systems were running about $30,000 to $40,000 per system, and not one system had an answer for everything. And I wasn't doing enough single teeth to justify it. So I had an oral surgery group upstairs in the same building I practiced, and so I said, okay, I'm done with implants, I'll just restore them. But then I got 3D 6-7 years ago because I was tired of seeing implants come back from oral surgeons where I couldn't restore them or they weren't ideally placed. So now we do 99% of our own implants. We do them restoratively driven. We plan where the final crown's going to be, and now we do surgical guides for 95% of our cases, especially since I can mill a surgical guide in the office in an hour. Somebody breaks a tooth at 8 o'clock in the morning, I can have an implant guided that afternoon.
Talk specifics. What 3D? What software? What
okay,
system?
So the beauty of Sirona is Sirona has a system of integration. So within the system, I can take a Galileo scan, I can take an intraoral scan with my Cerec unit, and I can integrate those two into each other. Now,
okay, so for the audience, Galileos is
3D,
Sirona's
3D imaging.
CBCT.
Right, CBCT. Okay. So we have, with Sirona, you have small volume, you have a medium volume, and you have large volume. I'm a real believer in as big a volume as I can because I really want to treat as much for the patient as I possibly can. But because CBCT shows me the bone and everything, and virtually I can seat that implant in my cone beam image, I don't have any pucker factor as far as putting implants in. My first guided implant took 12 minutes. You know, I was almost ashamed to charge the patient what we charge for them. But you have to realize all your planning is done ahead of time. So why should surgery take an hour and a half to put a single implant in when you can do it in 10 or 15 minutes? And you can do it with a better outcome for the patient. It's going to go right where you want it. Plus, the patient doesn't have any post-op problems. It just there's no pain, there's no sutures, there's no second visit to take the sutures out, and certainly there are cases that we have to graft and stuff like that. But now putting implants is really viable for the general practitioner.
And okay, it's safe to say that in the United States, 94% of crowns
right
are on the first are single unit. So if a lab gets 100 crowns, 94 out of 100 times,
okay,
it's a single crown. The most common tooth to be crowned is a first molar. The most common tooth to be missing is a first molar. So when you're saying that your first implant took 12 minutes, are you talking about any of the four first molars?
Any of the four
3,
first molars.
14, 19, 30?
You bet.
Okay, well, talk about that, because I know what she's thinking. She's thinking, are you not aware that there's a sinus above the upper molar? And are you not aware there's an inferior alveolar nerve on the lower?
But when you can see that in a CBT scan, so my Galileo scan shows me exactly where the sinus is. It shows me the width of the bone. It gives me an idea of the density of the bone. So I can track the nerve canal completely. I have for the lower, and I can see the sinus on the upper. So if I know that the sinus is 8 millimeters away, I can punch it right up to the sinus, or I can punch it into the sinus. I can put bone up in there. I can do a vertical sinus lift if I want to.
We'll talk about that, because I think a lot of naysayers are saying, okay, the most common tooth is a first molar, and they usually only have 5, 6, 7, 8 millimeters. So talk about that sinus.
Well,
let's talk about the upper, and then we'll switch to the lower.
So let's talk about the upper sinus. So then, you're going to get your training. So what implant system do you want to use? And I use 4 different implant systems, and there's an implant out there called Bicon, which is a plateau design, which is a short, squatty little implant, and you can put those almost anywhere, and put a 5 millimeter implant in, and I can have a restorative platform on top of that is almost 5 times the height of the implant. So even if it's way up high, but I got 5 millimeters, 6 millimeters bone, I can put a short Bicon implant. On the other hand,
and that's really changed in our careers, hasn't it?
It has.
Because back in the day, everybody just thought it had to be as long as possible.
Yeah, needed a big screw,
and now it's short and fat is getting
Yeah, and even in Nobel and Zimmer's implants, we now have 6 millimeter implants that are wider. So we have 7 millimeter wide implants, 6 millimeters in length. We have 5 7x6s. We have a lot of surface area in a smaller implant. And so if we don't have a sinus, but what we also have to understand, a sinus isn't that oh God, I got that forbidden area. It's an area in the skull that's got a lining, and it's a space. It keeps our skull light. So you learn that if I have to break into the floor of the sinus, and if I have to pack some bone, or if I have to just push the implant up into the sinus, as long as I don't violate the membrane, I'm fine. I've got a sterile piece of titanium that's going up.
Would you also say, as long as they don't have a sinus infection, it's usually not an issue?
It is.
But if someone has a cold, has a sinus infection, has something like that, then you really...
I want to clear that up first,
and
then I want to do the implant. I don't want to go into an infected area if I possibly
can. And if you are placing an implant in the maxillary first molar area after surgery, do you prophylactically put them on antibiotics? Or
it depends on what's going on with them. If I have to graft anything, I usually put them on an antibiotic. But if they had an infection, let's say I had an immediate extraction, I'm going to cover them with antibiotics, probably a Z-Pack or something that's short term but lasts a long time, to to knock that down and give me a little more success, but I don't think it's mandatory. You know, there's a big discussion in the literature, do you or don't you? And I just do.
Okay, now let's switch to lower. I don't want to do these implants because I really don't want to get a paresthesia. I don't want to slam a titanium implant into the inferior alveolar nerve.
I'm not worried about paresthesia. I'm more worried about the lingual concavity and perforating lingual concavity and having a bleeding artery and having somebody bleed to death because I went through that really nice lingual concavity that people don't see. I think that's a bigger concern for dentists down on the lower arch. Paresthesia is one of those things that if you happen to put pressure on the nerve, you can back up an implant or you can take it out and put a shorter one. In the time I've been doing implants, I've never had that because we can actually section the bone in any direction, and I can show you exactly where the nerve canal is. That's a real comforting, procedure. And you do this in front of the patient. I place the implants virtually in the software, and patients then see right where we're going to put that implant.
And you do that in front of the patient? You do that?
Oh, totally. It's about a 5-minute.
And you do that in the operatory, or do you have them go into a
You can either do it in a consult room or you can do it in an operatory. Your hygienist can do it. Your assistant can do it.
How do you do it?
I do it both places.
Both places?
Yeah.
And what software are you using?
I use the Galileo implant, the Sidexis.
The house software?
Yep. With your system, you'll get the software, Sidexis, and then you get Galaxis implant.
So let's talk numbers. So how much is a Galileo CBCT?
Full volume's about 140,000. Small volume can be 90,000.
Okay, say that again.
Okay, for a large volume, the flagship of Sirona's product, probably around 135, 140,000, depending on what you want to add on to it.
And that's the one you recommend?
Exactly.
Okay, what would the lease payment be on a 5-year lease?
$2,100.
Okay, so how many implants would this person have to be placing a month to be at a break-even point?
I don't think you even have to place an implant to break even with this, because the beauty of CBCT is that you get to section teeth and see stuff that you cannot see in 2D x-rays. I can show you case after case where you look at a pan, you look at a periapical, and you go, you know that tooth that's been sensitive for the last 5 years, and you have those patients come in and got that tooth, it's sensitive, and you look at it in a regular x-ray and it just doesn't, and all of a sudden you open up a 3D scan and you see that there's an abscess that should be showing up on 2D x-ray and it doesn't, or you see a fracture that you don't know that's there. So 3D imaging increases dentistry overall for you. You see, it's very humbling, Howie. I mean, if you've looked at 3D, you see your mistakes. You see your endos that aren't as good as you thought they were. You see endos that are done perfectly by a specialist that still fail. So suddenly it changes how you do dentistry and what dentistry you do. It makes you rethink how many molar endos you do versus and which molar endos you do instead of placing an implant.
I've noticed one thing in our lifetime. You have to admit, the percentage of apicoectomies on failing root canals has been trending downward. Wouldn't you say that?
Totally. I mean, if a root canal for me doesn't become successful the first try, it's not worth doing it again.
And do you do a CBCT before your molar root canals?
We take a CBCT on every patient in the practice. So we have a scan. If you become a new patient in our practice, we'll do a scan and 4 bite wings.
Okay, so what would you say, devil's advocate, if someone says, well, that's too much radiation?
I'm going to tell you that if you're doing a full mouth series, plus bite wings and everything else, you're giving them too much radiation, because a full volume is 67 microsieverts or less. And add 4 bite wings in that, it's about half of what we used to do when we did film-based full-mouth surveys. And I'm sure that you've never had the issue like I did, where you did a full-mouth series and it didn't develop properly, or somebody didn't take the right films and you had to add films to it. And suddenly you're doing a lot of radiation. And it's still less than what the medical profession does.
One more devil's advocates.
Okay.
That's a lot of storage. Where are you storing all these files? Are you using a cloud-based system,
No,
hard drive?
Hard drive, and it's really not. You know, a terabyte of storage anymore is dirt cheap. So we're into mega terabytes of storage, you know. So I think we could store about 6,000 scans.
What particular, on what?
We have a server for our CBCT, and then we have a server for our practice management software.
What's the name brand?
Okay, so I'm using EagleSoft. So we have I have a Dell server, a regular old whatever Dell makes for a server for my practice management, and then Sirona provides their own servers for their CBCTs. So it's called a reconstruction because when
is it a
all
Dell
this
server?
No, I have no idea what it is. But
isn't that funny? We're so old. We saw Dell do an IPO and go public, and now Dell's delisted.
Yeah,
I've lived through the beginning and the end of Dell. But so you don't think the storage is really an issue?
Oh, storage isn't. Because, if you don't like hard storage, do cloud-based.
Okay, I want to ask you another question about some dentists when they're looking at a CBCT, they're saying, well, you kind of more want this one if you're more placing endos and implants, but you kind of more want this one if you're doing orthodontics.
If I'm an endodontist...
What would you say to a general dentist who likes to do ortho and endo and implants?
Okay. So I get this question all the time because...
See, I'm not making this stuff up. See, he said he gets this question all the time.
I do.
Hugo's always saying your questions are so stupid.
No,
so
this is a perfect question because you have to look at what you want as far as, when you buy a handpiece, what do you want? Do you want something that's light or do you want something that's efficient? When you buy cone beam, what do you want? Do you want to see the TMJs? Do you want to see the joints so that when I do restorative, I don't restore somebody in an improper position? Do I want to see airways? Do I want to treat the patient? There are tooth dentists and then there are dentists. There are people that only see a patient for a tooth. But I believe that we should treat as much, and we should be, as a general dentist, the quarterback and not throw everybody to the wolves. You refer a patient to an ENT, you refer a patient to an oral surgeon, you refer a patient to an endodontist. No, I want to control that. I want to know who's going to treat you and how they're going to treat you. I want to know what your condition is. I want to know if you have the possibility of sleep apnea. I want to know what your airway size is, because a lot of people die today of obstructive sleep apnea, and we have the technology to evaluate that for people. So I can't tell you how many people I refer out for sleep studies so that instead of breathing through a McDonald's straw, they can either be on a CPAP or an oral appliance to open up their airways. And now we can measure that airway, and we can actually do a scan before, put them in an appliance, and now measure their airway after they've been in it for a while, so we can see the volumetric changes in their airways. That's huge. I also want to be able to see their sinuses. How many teeth up on the maxilla have been treated, or people treated for sinus infections, when they really have an abscessed tooth? And if you don't have that volume that shows it, we're treating the wrong thing. So people are over-medicated with too much antibiotics because they think they have a sinus infection, and really they got a blown out number 2 or number 3.
So you're answering so which CBC would you get then?
Big.
The big.
You know what?
You're calling that the large volume?
The large volume.
And that'll work too with your molar endo and single plant?
Totally, because I can actually even take a large volume and I can enhance an area, so I can pick a first molar or second molar and get even a higher resolution. So, you're going to look at pixelation in those areas. So if I were an endodontist and all I'm treating is a tooth, then I might go to a small volume. If I'm an orthodontist, I'm going to go to a big volume because I want to see what's happening if I take little Johnny and I take him from a class 2 to a class 1, and what's happening with his joints. Or if you got a class 3 patient.
So a general dentist, so you'd recommend large volume?
Sure.
Yeah. Well, anything else? You're a wealth of them. I'd love to get an online CE course from you on Dental Town.
Well, I'd love to do one.
I would love it. We passed 205,000 member dentists now.
That's awesome.
Howard Goldstein put up 350 courses, and they've been viewed over 500,000 times.
Yeah.
And I think you're a wealth of information. Is there anything I'm missing that you'd want to tell these dentists?
No, go to Dental Town. Find out about me here in the future.
And also I want to say that you're from Iowa, I'm from Kansas. We both you practice in Kansas City. I get a lot of emails from the young kids that they're kind of scared. They're often asking, "Do you think the glory days were last?"
No.
Do you think we passed the glory days?
No, I think we're just getting into the glory days.
Well, tell the young dentist who's scared, because she's saying to me, I doubled down on $350,000 student loans. I'm buying a practice for $600, and the economy, Obama, blah. What do you think? Do you think the good days are ahead of us or behind us in dentistry?
I always think they're ahead of us. When I got out of dental school, Howard, how much were you in debt when you got out of dental school?
Well, I was $87,000 in student loans in 1987. So real and constant dollars at 2015, that'd be $250,000.
Yeah. I got out of dental school in 1980, and my wife and I were a total of $33,000 in debt, and I thought I was going to die. I thought, how in the hell am I going to pay this off? And, you pay it off and you go ahead. But I believe that the cost of dental education is a number one pressing problem in the United States these days, especially when you have new dental schools opening up that charge $100,000 a year in tuition. There's a point where they can't pay it off, and we're getting closer to that, but there are options as far as how you practice. I look back and I look at my buddies that went in the military and that practiced 20 years, that come out as full-blood colonels and have a pension and their 20 years of service, and now they're in private practice or teaching or doing that too. Those are choices that everybody has available to them. So there are options. Technology will only increase how much dentistry we can do and how we can be more efficient. So, placing implants, is we can place implants more efficiently. If it takes a half an hour to put an implant versus where it used to take an hour and a half or 2 hours, that's a pretty good per dollar per hour income. But you have to learn to be more productive. You hit it earlier when you said, they're only doing 20% productivity during the day. You got to be 80 to 90% productive during the day. Those other little checks have to kind of go away. You have to get good. You have to learn more. The practice of dentistry is a practice. We keep learning, and you can't. Continuing education is so critical, and you offer some of the best continuing ed out there.
Hogo does.
So Hogo
does.
Yeah, he does, and
with a name like Howard, though, how could he go wrong?
I had to change my name to Hogo because of him.
Well, I understand that, but
so let me ask you this question that we get all the time. I'm just going by all the emails we get. You got out of school in 1980. What percent of dentists worked for a corporate chain that was in multiple offices in 1980? Versus what percent do you think that is in 2015? And then I have to go out on a limb. Okay. What do you think it'll be in 2030?
It's growing.
What was it when you got out in 1980?
I didn't know about corporate dentistry when I got out in 1980. It just didn't exist.
So we'll say that's zero.
And you had more people in the military. You had probably 5% of your class that went in the military, and everybody else went in private practice. And today, probably 50% of the dentists getting out go into corporate dentistry, partly because they will pay you a salary, plus break it down into a commission, and you've got those huge loans. So it's changing the atmosphere. The difference is going to be how do the baby boomers sell their practices? How do they transition to the next generation? Can you find dentists are going to have to be a little creative into bringing people in as far as associates and making them partners within their practice and making it financially affordable for them to buy in and be part of that corporation or that practice, and then transition that over a number of years. So you're going to have to be creative as a dentist. You're just not going to be able to expect that kid to go out and say, okay, banker, give me $450, give me $1 million, because it's not going to happen today. So the financing of practice transitions is a big change.
And it's also interesting, at the end of World War II, believe it or not, most people don't believe this, but the average American female at the end of World War II in 1945 was having 5.1 babies. So back then, when the older people wanted to sell their businesses, there were more people wanting to buy their business than there was people selling it. And now, it's 2015, and it's reversed. So when you go to like business brokers, like in Arizona, that are trying to sell, old man farmer, 65-year-old $1 million business that's doing $3 million a year. He's taking home $1 million. He wants to sell it for $2 million. I mean, there's like 5 guys selling for every 2 kids looking at businesses to buy.
Yep.
So it's really a buyer's market for a business in general.
And even that, so you see a lot of private practices now selling to corporate people because you can get
liquidity.
Paid. It's liquidity, exactly.
And that's one of the biggest explanations of corporate dentistry is people like Rick Workman went out and got a huge line of credit from Wall Street. And then going into small towns like Bruce Baird and all these guys and being able to just buy, whereas there's a liquidity problem. You also see that in car dealerships. So if you have a big car dealership and it's worth $10 million, well, who are you going to sell a $10 million car dealership to? Because anybody with $10 million doesn't want to buy a car dealership.
Nope.
So you had some rollout chains that were going around. You got a big loan, a line of credit.
Right.
And we're going around and buying up all these car dealerships that didn't have liquidity. And what Rick Workman and Heartland Dental have done for a lot of older dentists is provided liquidity, someone to sell their products. So that's a big part of the corporate dentistry equation is liquidity. But, well, hey, thank you. I know I just stalked you at the Greater New York. I saw you stop by, and me and Hogo grabbed you. But
well, it's always good to see you.
It's good to see you, and I hear great things about you. Love to have a course from you online on Dental Town sometime. We really would.
And then I'll talk to you a little more because we've opened a training facility in Kansas City.
Tell us about that. What's the website for your training facility?
Well, you know what? We're in the process of building the website. It's so new. So we bought a new facility, and we now have an 11-chair dental office and about a 3,500 square foot training facility associated with that, with a full surgical suite. So,
wow. What are you going to call this?
It's Corporate Lakes Education Center. Corporate Lakes Dental is the name of the practice, and we're in an area called Corporate Lakes.
Your own independent?
It's going to be an independent, so I'm not obligated to any manufacturer or supplier.
Which is very rare in CAD-CAM. I mean, most of the CAD-CAM educations, I would say, owned by Sirona, Patterson.
Well, it is, and I wanted to be
Scottsdale Center, the Spear Center.
Yeah, I wanted to be an independent. I didn't want to be really obligated to Sirona or to Patterson or to a Scottsdale Center. So we're planning on doing a lot of Cerec courses. We're doing a lot of integration courses where if you do buy 3D imaging, whether it's a iCAD, a Galileos, whatever, you still need to know how to read images. We want to do advanced radiology. So, you always get basic training, but then where do you go when you need more? So I want to bring in some good oral facial radiologists and put on some 2-day courses so you can...
What ones are you thinking of? Who are your favorites?
Tom Deal is a favorite, and I've got a good friend down in Atlanta named Tom Kaufman who's just a whiz at sinus pathology, and maybe twice
you know both of them?
No, I know.
Okay, so
can you email me their names?
I will.
I like that. I like Dale Miles, and I like that.
Okay.
Who's the woman? Shawnee Gonzalez.
Yeah,
Shawnee Gonzalez. She's a
okay.
real. You know her?
No. So,
she's a real whiz. But anyway.
So, and so in the Midwest, having grown up in Iowa, and you're from Kansas? Wichita, Kansas, that's right. So we're just kind of an isolated area, and a lot of people don't want to leave their practice and go to Arizona, Texas, California, and if you're from the East Coast, it's a big trip. So we're really situated in a really neat area because Overland Park's great. We got a lot of little good restaurants. We got a lot of good hotels.
Did Kansas City ever get a baseball team?
Nah, hell no. It's just the best baseball team this year.
It's funny. I was in dental school when they won the World Series against St. Louis.
Yeah.
That was in. I was in dental
85.
I was there 84 to 87. And I couldn't believe it during the World Series. It was 30 years ago. I'm like, wait a minute, I was there. It couldn't have been 30 years ago. How did that feel to be in town when they won the World Series again?
I was really proud of Kansas City because what was really, really just heartening was The celebration after the World Series, the Tuesday, a gorgeous 65-degree day, and 800,000 people showed up. And in Kansas City, where do you put 800,000 people? I mean, I think there would have been 200,000 more, but they couldn't get anywhere. So there's some photos out there that show, and you're aware of the Memorial and Union Station, and it's a sea of blue, and you have 800,000 people, and you had 3 arrests for disorderly conduct. You had no vandalism.
And that was probably my cousins.
No. And so you got to be proud of the community, how they celebrated.
I want to say something. I've lived in Kansas City, and I live in Phoenix, and Phoenix has better weather in the winter.
Oh, absolutely.
But I'll tell you what, Kansas City with the plaza, with the West Court for the bars, for the culture, the museums. Kansas City is, if you go there when the weather's right, if you don't go there in February, but if you go there when the weather's right, I think it's one of the coolest, classiest, most cultural cities in America. But I want to go back specific. You could have gone and made it an all Cerec center, but
right.
You stayed agnostic. So I'm wondering, on a business point of view, is that because when the big company that bought Plan Mecca out of Helsinki, Finland, bought E4D at Dallas, Texas, do you think that is going to be a major competitor someday? And also at the Cologne meeting last year in Cologne, Germany, there were some other CAD-CAM entrants to the market from Korea.
Right.
Do you think there's going to be lower price competitors entering the marketplace? Or
I don't know
if price walked away with this.
I don't know if price is an issue. It has to do with quality and what you can do with the technology. Because certainly, when you look at intraoral cameras, just in general, you can buy a $100 one or you can buy a $4,000 one, but they do take different pictures. Sirona invests a lot of money in R&D. And because I've been a beta tester for 10, 11 years on the Cerec side, I see what they have to do and what it takes to make the software as good as it is. And so, you can have you can build a better camera, you can build another camera. I don't think you can build a better camera, but you can build a good competitive camera. But now you've got to have a system that integrates totally. And Sirona had this vision of this integration. And there's nothing more frustrating than you buy a camera from company A and you buy a milling chamber from company B and you buy a cone beam from C, and now you want those 3 to work together seamlessly, and they don't, but they say, yeah, they do, but who do you go to when something goes wrong? And the cost of part of that is when you buy a Sirona product, it's under one telephone number. If I have a problem with cone beam or milling or imaging, I make one call and it's fixed. And it works. So I can be more efficient. So you may save $20,000, but it's like seeing the forest for the trees. You save $20,000, but it costs you $400,000 in production. Is that a smart move?
Yeah, and also when you go into a dental office and labor is the largest expense, it's 24 to 28%, and equipment's usually 4% or less.
Right.
So you have labor all confused and needing more training and not knowing how to get the CBCT into the this and that and the CAD-CAM, and so you have labor all standing around, not getting it done, needing more continuing education, needing more this, needing all that because you save money on equipment.
Right. So the training facility's about that. Okay, so it's a big investment, so why not have an area that people can drive from 5 states? So you can come from Nebraska, Minnesota, Iowa, Missouri,
Oklahoma. So when's your center open?
It's open. We'll have a curriculum up online probably by the end of January, and really 2016 will be a kickoff.
Well, when it opens up, send me an email, and I'll push it out on Dental Town and social
I appreciate
media
that.
and all that
I would
stuff.
love to start recording some of your training sessions.
We could do that.
Could be your online.
And you know,
conduit.
it's counterintuitive. Here's what is counterintuitive about online C, and I'll tell everybody this. They say, well, I don't want to put my course on Dental Town because then no one's going to see my lecture. And I say, well, which concert is the last one you went to?
Yeah.
Oh, you went to U2, and that's because you have all the records.
That's it.
And everybody that puts an hour course up, that's like, U2, then they want to come see your band live.
Yeah.
And no one's going to, and it's the same thing with bonding agent. You know what? You can watch a bonding course on Dental Town, but until you go into a course where you put on the bonding agent yourself, then bond, and then test your bond strength and realize, wow, if I don't scrub it for like 20 seconds, I don't get these great bond strengths.
Exactly.
And I was just in my office, I was just painting it on and curing. And when I do that here, the bond strength is half. So there's always, dentists work with their hands. They're always going to work with their hands. But all the people that do the online CE, their attendance is the highest. And it's just like you listen to U2 on the deal or the Rolling Stones, so then you want to go see their concert. And I think the more courses you filmed from your facility and put online from Dental Town, the more people get to meet you, get to see you, get to like you, and then the next thing you know, they're going to your center in the flesh. Because in the end of the day, doctors work with their hands.
They do.
But hey, I think
Howard,
you're an amazing man. Thanks for spending an hour with me at Great
Hey, you're welcome. It's always good to see you.
All right, thank you.
Howard, thanks.